speak for about 15 minutes or so to introduce this thinking and then open it up to questions. We'll make the recording of all of this available afterwards for people who fancy their punishment twice in terms of this sort of thing. Please type your questions or comments into the WebEx kind of Q&A box, and we'll come to those. We'll come to those at the end when we're looking at things. My name is Jonathan Flowers. I think about local government strategy for Capita and our clients, and I'm joined in the room and online by my colleague Jason Cross, who's hosting this WebEx. The purpose of this thinking, the aim of this thinking, is really to help us come to terms with what's going on around health and social care. My favorite quote about predictions is the one at the top of this page. It's by a Nobel Prize-winning physicist called Niels Bohr, and he said that predictions are hard, especially when they're about the future, which I think describes that very nicely. There is an incredible amount of complexity and uncertainty within health and social care and the integration of the two. Also, an incredible opportunity, if we can get it right, to improve people's lives, really. And we think that it's useful to have different kinds of conversations because of the complexity. We need differently structured conversations to help system leaders engage with each other, to reflect on and to lead the system. So what this approach does is it tries a tool. It's called scenario analysis. It's commonly deployed in the private sector. I would say that when it's deployed in full strength, in industrial strength in the private sector, an exercise like the one we're about to do today might last kind of 2 or 3 days. So this is a kind of abbreviated version, but it's quite a useful tool. And a couple of years ago, I wrote a paper, 4 Features for Local Government, which is a different kind of exercise, which is similar kind of exercise, but obviously different content than we're looking at today. And I found that incredibly useful with a number of local government council management teams and so on in terms of thinking about the future. So we thought we'd apply a similar kind of approach to health and social care integration. Just a word or two about scenario analysis. It's a way of forcing us to think about deliberately extreme futures. It's potentially thinking about things that we may not like, which is actually quite a useful exercise to go through. It's also a tool for system leaders to think with, rather than being, for example, a way of predicting exactly what the future is going to be. It's also another thing that scenario analysis isn't. It doesn't claim to have covered every conceivable possibility of every dimension of every future. I mean, for example, in this exercise, we're not considering the impact that would arise from a massive game-changing technology. You know, for example, if there was a vaccine that cured dementia or something like that, would have a huge impact on the health and social care system. And we're not considering those kind of out-of-the-box type scenarios in this exercise. So what are we considering? Well, a little bit of trial and error has told us that it's actually quite useful to look at these particular 2 dimensions of uncertainty around the health and social care system. The first thing is that, at some point in the future, and we've taken 2025 as our baseline for this, we will be somewhere on a spectrum between, at one end of the spectrum, being extremely user-centered, the entire health and social care system integrated around the user. At the other end of this particular spectrum, there's the extent to which the thing might be oriented around professional silos, around services, pretty much the way that it is at the moment. The other dimension that's quite interesting to look at is whether in 10 years' time the health and social care system is very strongly locally directed or whether it's very strongly centrally directed. And some of that will become a little clearer as we go through the process. But essentially, the way that the scenario analysis exercise works, and you can see from this diagram why there are always 4 features if you're looking at a particular, this particular method of scenario analysis. What we do is we take each corner of these quadrants in turn. So we'll start off by considering a situation where there is central direction and it is very user-centered, and carry on around each of the 4 extremes of the scenarios that we have. So what we do is we take each corner in turn and we start by telling a story. We start by telling a story looking back from 2025, as if we are looking back from 2025. What happened that meant that we ended up in this corner? It helps us to think about what that particular future will be like. And then we think about, so what does that mean for the key players in the system? And especially, what does that mean for the service users and their carers? So the way this unfolds, the first example is Future 1. So this is the one in the top right-hand corner of the quadrant, and it's the one where we are centrally directed and user-centered. How might we end up in that kind of world? Well, the answer, looking back from 2025, is that there were a number of specific incidents of failure, or from kind of 2015 onwards. There were a number of spots of failure, which led to a real outcry in the press and in other places around this whole notion of a postcode lottery, and basically meant that over time, services were assimilated away from local government and they were put into the NHS. Now, as we know, that would create huge kind of cultural and delivery challenges within the NHS. But in the end, in this particular feature and how this came about, was by increased use of personal health budgets. Being trialled at the moment, some very encouraging early signs coming through from those. So you could see a world in which personal budgets for health and social care start to integrate. And that could work well, particularly with the use of user-centered technology and web portals and those sorts of things. As we look back from 2025, we can also see that this fitted a trend towards individualism within society. It's far less common now that people who want to go on holiday will throw themselves at the mercy of a travel agent. They're far more likely to look on TripAdvisor, they're far more likely to make trade-offs. So, for example, to get an earlier flight, which might be a bit cheaper in order to have a nicer hotel. That's very consistent with the kind of approach that we're thinking about here. So that's how we ended up in a world where we had nationally set and administered personal budgets across health and social care that are therefore integrated in the needs of the user. So what are the implications of that? Well, for users and carers, it means that they have the key sense-making role, really. It's their role, as it is in any kind of personalization situation, to make sense and be making the choices and so on. That does leave potentially an issue for people who can't cope with that, and various support mechanisms would need to arise in order to support that. I think this could be quite a challenging world for providers, actually, because if you've got an extremely vibrant marketplace across the whole country in terms of the kind of offerings, that could be quite a tricky kind of world. You're selling to people now. You're presenting your offer to individuals rather than necessarily selling things through CCGs or through councils. An interesting challenge for the social work profession because you've got a mixture of places where social workers are providing services within the marketplace, but there will be other social workers who will be in, as it were, the NHS system in this world, actually making the assessments and prescriptions and so on. Some interesting challenges for regulators too. I'm not particularly going to dwell on that, but if anybody's particularly interested, we can talk about that later on. I think basically the system leaders as a whole, the challenge is going to be about how you use this kind of mechanism to create joined up policy, how you use a very user-centered, very personalized approach to create policy. I think the challenge for people within localities, given that all of these things are basically being driven nationally, is going to be thinking about how they can make linkages to other elements which are really, really important for people, like housing, and how they can make sure that there is a good and vibrant market within their particular locality. There may be some areas where the market is less inclined to touch. So that's our feature number one. I went through that one in a little bit more detail, but we can go through some of the others a little more quickly. So as we move around the clock face, as it were, we move to feature number two, which we call Me in My Place. So this is one where we stayed to the right-hand end of the diagram in terms of being user-centered, but now we are looking at something which is very locally directed. And how did we get to there as we look back from 2025? Well, basically, as we look back from 2025, devolution, the Greater Manchester devolution and the various ones that came after it, the decentralization generally, it worked. We discovered that if you actually put controls in the hands of more local people, able to make local decisions and manage integration locally, that worked really, really well. And part of the reason why it worked really, really well is that a whole bunch of the stuff that local government had been doing for a while you know, from 2010 to 2015 in terms of coping with the pressures. Things like getting seriously into user-centered design, things like getting into the kind of cohort approaches that were exemplified by troubled families. They applied those sorts of things. So basically, within a particular locality, over the period from 2015 to 2025, systems were designed that would meet individuals' needs well. All the kind of customer pathways, all of the key journeys that were needed were met within the context of a locality. And because there was a lot more closer working and a lot more co-location, the professions became closer, and there was a lot more cross-training, a lot more shared assessment, and so on. Also relevant in this kind of situation, as a way of having to pay for all of this, some of the skills that local government had acquired around decommissioning and engaging people around decommissioning services were able to be deployed as well. So here, in feature number 2, we have an integrated pathway for a user, the mechanism for which will have been determined locally, which will mean that there will be different pathways, there will be different choices made in different places. So what are the implications of that? Well, it gives quite a strong importance to the local authority as the sense maker for a locality. In some respects, this is possibly the easiest world for users and carers because an integrated service will have been designed for them that will take them through a process that has been designed based on local priorities, local needs, based on what may be available in the market locally, for example. Potentially quite a challenging world for providers here because if different things are happening in different localities, they'll need to be able to adapt to different needs. And interestingly, because we're talking about integrated health and social care, providers who are just providing health services or just providing social care services will either need to partner with people very closely, or we may even see some mergers of organizations across that boundary. Some very significant challenges for professionals here in terms of their practice, their training, the ways in which they work, what accreditation means in this kind of world. Lastly, system leadership. System leadership in this world is happening very much locally. And it is about working with elected people to create a narrative for the place. What are we doing in our place? And making sure that the kind of information and decision mechanisms are supporting that, which is very much the kind of world that would be very familiar to people who've worked in a local authority environment. But as people from the NHS who are less familiar with that are absorbed into this system, there'll be a kind of training and kind of development opportunity for people in terms of that sort of thing. So I'll push on around. The third feature is one that I call local drift. So in this feature, we're still talking about things being driven very locally. But in this world, this is the first time where we're looking at a situation where we're retaining the service and the professional silos, if you like. So how do we end up in this world? How do we end up in feature 3 by 2025? Well, as we look back, we see that the health and wellbeing boards within a locality for pulling together commissioners and the service integration boards where they occurred in the context of combined authorities that had health and social care integration, they work really well. They're very important within a locality now. They're spending a lot of public money. So that's all very good. Local commissioning is working really, really well. It's alive and well. But because of worries about litigation, because of some of the inevitable kind of boundaries that exist between professions, and because ultimately it was very, very hard for DH and NHS England to give health money to local councils, it stopped the total integration of these things. But what we found was that over the 10 years, at a local level, because of relationships and so on, a whole bunch of workarounds were developed, and they were basically good enough. How does that look? What does that mean by way of implications? Well, firstly, it means, again, we will have a variety of different local practice, and it's the boards. It's the health and wellbeing boards and the service integration boards who are the sense makers for their area. Its users are having to navigate the system and are a little bit dependent on how well the particular local area helps them to do that. This could be, I think, a really quite challenging world for regulators because there's a lot of very, very different things going on, and they could be left with simply enforcing minimum standards. Although I think that there is lots of opportunity for regulators in any of these laws really, but especially in this one, to add value to the local commissioners. Where's the system leadership? Again, because this is locally directed, the system leadership challenge is very local again. A lot of it's about governance, because it's governance across different commissioning streams. It's about ensuring that that governance works, and crucially, it's about relationships. I think one of the things that's really interesting about this potential world is that we might see far less movement of people around the system, because things will be so different in different places. They will depend, good practice will depend so much upon people having good relationships together, so that relationships can reach across the silo boundaries, that it could be quite difficult for people to come in from outside into that sort of situation. So succession planning will be really important. The last feature I describe as care as a benefit. This is one where it's centrally directed and also quite siloed, quite service and profession centered. As we look back from 2025, how did we end up here? Well, the first thing that was notable about those particular 10 years was that there was less and less money for adult social care. It got reduced and reduced and reduced. One of the consequences of that was the councils got very good at making sure that if anybody was presenting with social care needs, they made certain that they were claiming all of the benefits they could be entitled to. They were keen to get as much money as possible into that family or for that particular individual. And what we saw over the 10 years was that where there were hard cases, where there were difficult situations, the government decided to use the benefit system to top that up and to tackle that instead. So over time, rather than having social care services assimilated into the NHS, as it was in the first scenario that we saw here, we see older person social care essentially being assimilated into DWP. So it becomes a benefits service. Now, because the kind of benefits and the kind of claimant mentality and the universal service mentality of the NHS never really merged, so neither did the services really, they stayed quite separate. And in this world, we find social care being accessed by claimants through various national benefits that may exist. But then that means that they have resources that are appropriate that they need in order to access services. It also means in this kind of world that national organisations who have an interest in particular things such as kind of Alzheimer's or whatever are able to lobby nationally. So this world might be a little easier for people like that. What does this mean? What does this mean for people? Well, it would mean users and carers having to make the best they can of this particular world, and depending on how well that will work will depend on how well support and various other markets develop in response. It's possible that some of the national regulators and larger providers may find this feature a bit easier because it's national standards across the whole thing. Could make it quite difficult for smaller providers depending on how that's rolled out and how various contracts are let by the commissioners. For health commissioners, this is a relatively straightforward situation. They carry on as they are now, but do the joining up that they can as best they can at the local level. I think this is potentially the scenario that's most challenging for the social worker profession. The social worker in the DWP side is much more about the kind of benefits assessment activity that's taking place at the moment. And to the extent that these services are provided locally, there'll be much more about providing support, possibly in the market, and actually market making. I think this would also be potentially quite a challenging world for systems leaders, joining up the various different policies. I think, though, that we could see things like the troubled families approach, helping people with the most complex needs. So those are the 4 features. We'll run through them quite quickly. What does this mean, you are probably thinking? Well, I think the first thing to say is that it's extremely unlikely that any one of these scenarios is going to play out to that full extent. These scenarios are designed to be extreme, and so they are. What could be interesting is we might see different combinations. We might see that within areas that have a combined authority that are looking at health and social care, we may have one situation with other situations in the rest of the country. We might find different situations in Scotland, Wales, and England, for example. But I think that it's a useful exercise to do, to think as individuals which of these features we might want to happen, which do we most want to happen, and which do we actually think will happen, which could be the same one, of course. All in all, to support a conversation about how system leaders can best influence the future direction as a whole. And so what we're going to do now, actually, is ask you to vote. In a moment, a poll will pop up on your screen asking you to indicate which of these 4 features you would want us to be in terms of your personal choice. And then in a moment, we'll do another poll asking where you think we will be. So if we can have the first poll up, and you've got a little time to choose one of these, A, B, C, or D, which of the possible features would you most want to be delivered? So please vote now. And do we have the answer? Okay, so we've got the answer. Hopefully you can see that on your screen, as I can. So we're seeing quite a few people didn't answer, but for the ones who did, and interestingly, this is quite typical when I carry out this exercise, there's a strong preference for the me in my place scenario. So that's the one with local determination and the strongly user-centered sort of approach. Okay, so that's interesting. So now we'll do the other poll, which is the one about where you think we will end up. And it'll be interesting to see what comes out from that one. Okay, it's counting up the poll. You might want to take this time to think about some questions in the Q&A boxes. Okay, and we end up with 5 people going for local drift. And again, I have to say this is emerging as quite a common theme across the various presentations that I've done of this in various places, with generally quite a strong desire for the me in my place as where people would want to be, but a lot of people thinking that we're likely to end up more in the kind of local drift type scenario. It would be interesting to know whether the people who expressed the preference for regulated consumerism and care as a benefit were also the people who said that that's where they thought that we would end up. I'm not quite sure how we get at that in the context of the webinar. So that's essentially some of the thinking. It's interesting that the views of the people on this call fit very well with other organizations and other places where I've done this particular presentation. Are there any questions? Do we need to allow people to speak? We haven't had any text questions come through, so we're just going to try and find a way of opening this up for various people to make comments or contributions, which could be a little tricky. Okay, I think you are now all able to speak. Any questions or comments? Who'd like to go first? Can I ask the person who picked on care as benefit to give us a little story as to why you think we're likely to end up in that particular world? nobody coming through there. But we do have a question from Kevin Thomas, the role of the clinical commissioning groups in these scenarios. I think they will be it's a very good question, and they'll be very different, I think, in each of the scenarios. So, for example, in the regulated consumerism one, I think that I think that in common with local authorities having less to do in that kind of context, I think there'll be less for CCGs to do as well. I think that the centralisation and the use of the personal budgets will result in a much smaller role, to be honest. I think the me and my place scenario, there's a much more active role for clinical commissioning groups, working very, very closely with local authorities, as indeed there is in the local drift scenario, where, and arguably, I suppose the local drift scenario is one where the CCGs have the strongest role, because much more so than in the me and my place scenario, they will be managing the health funds, if you like. But again, in scenario D, in the carers benefit scenario, the local providers of service, or the local commissioners of service, have much less to do. Does that make sense to you, Kevin?
Can you hear me?
I heard a very, very faint person saying, "Can you hear me?"
Is that any better?
Oh, that's a lot better. Is that Kevin?
Yes, we have contact. I've made it work. Yes, that makes sense. It does make sense to me.
What were your thoughts? What were your thoughts, Kevin, about where you would like us to be and where you think we might, and where you might want us to be?
I think I'd like us to be in me and my place.
Yeah.
But I was oscillating between the centralised, so carers benefit and local drift, because my experience to date is it never quite joins up.
Yeah. Yeah.
And I think the real challenge will be, how do we empower the users and use technology effectively? I know that's not one of the scenarios here, but how we really put control in the hand of the users.
I think technology underpins quite a lot of these, actually. I think that, so for example, I don't think the regulated consumerism one would really work if there wasn't very good technology support. And I think it'll be quite important too in the me and my place scenario. I think the interesting thing will be whether, the extent to which different places develop very different things. And I think this whole notion of, the postcode lottery comes up here. And I've been doing some thinking about that, actually, because I've been doing this presentation in a few places, and it seems to me that the word that we focus on when we think about postcode lottery is the word postcode. And I think, in actual fact, the word that we need to look at is the word lottery, because I think that if you think that your service provision is random, wherever you are, it's kind of random whether or not you get a particular service or not, then you're going to be very unhappy with that. But if it's done as a result of an engaged and deliberative process based on local democracy, local people having a say, and if local people choose that they're going to make something a bigger priority and something a lower priority, then that will be then that's not a lottery anymore. It's local determination rather than being a postcode lottery, and we need to be careful about the use of that word. We've got a couple of other observations coming through on the Q&A. So I suspect some will achieve B, maybe encouraged by funding, but not all will be able to manage it due to local issues, capacity, and poor partnerships, etc. Yeah, I think that's a really interesting point. Whoever said that, I think that an interesting question in this will be what the extent to which places that are able to achieve it will be allowed to achieve it. I suspect that the general mood music of decentralisation at the moment would allow that to be the case. And so maybe we would indeed see some places that were able to achieve those user-centered solutions because trust had been built up, because permission had been built up to allow that. And I could certainly see that within the context of some of the combined authority deals, for example, which are explicitly giving a structure and more permission for that, the places that have really, really good combined authorities and devolution deals might be able to achieve me in my place, with other places in more of a local drift sort of scenario. Oh, and then Alan Sharp, thank you for the comment here about NHS care is free at the point of need and social care is chargeable, still needs to be resolved as it will be a major blocker. Yeah, I think you're right. I think that I agree. I think that's fairly fundamental across all of this. It'd be interesting to speculate on the extent to which the NHS remains free at the point of use over the 10 years, of course. I mean, I'm sure a number of people would wish that it would be, but I know that at various points, various options have been considered around that. Yeah, the Barker report was particularly good on this one, I thought. It's a very good point. Any other questions or comments that people would like to type in, or would anybody like to say something? Okay. In which case, about half an hour in, I'd like to say thank you very much for participating in this today. I hope you found it useful. You will have seen from the page that invited you to this the links to a fuller paper which describes this in all in a bit more detail, and also has contact details, my contact details, if you'd like to continue the conversation in a different kind of format. So I'll close now. Thank you very much. Thank you very much for your time. Thank you very much for engaging with this.